So I was asked to talk about challenges, but I added in opportunities because, as we've heard, there are lots of opportunities in the field of amyloidosis, so it's important not to forget them. Okay, failed already. These are my disclosures. No. Okay, so neuropathy is important. We've heard why it's important, but there are a number of reasons. Firstly, someone may present with neuropathy as the first symptom of amyloidosis, so it's always important to keep that in the back of your mind when you see someone with neuropathy. But the other reason that neuropathy is important is that in Ireland, at least, reimbursement of the silencing therapies are only reimbursed if you have neuropathy with TTR, with hereditary TTR amyloidosis. So it's very important to be able to diagnose whether someone with hereditary TTR amyloidosis has a neuropathy or not, and to do that, really, you need to see a neurologist and a neurophysiologist. So, as we've heard, there is a HSE accepted and amyloidosis working group report and a model of care, and this was accepted by the HSE in 2022. It is not yet resourced. Myself and Emma were both involved in that guideline, and I know no one can read it because it's teeny tiny writing. And I don't know why our algorithm is so swirly compared to the UK ones, which are nice and regimented. But essentially, it requires, if you think someone has a neuropathy, you confirm it with nerve conduction studies, and if you think that that could be in keeping with amyloidosis, you check for paraprotein. If they don't have a paraprotein, you do a DPD scan. If that's abnormal, then they have TTR amyloidosis, and you just do a genetic test. So it sounds very straightforward. It doesn't require a lot of steps, but in real life, of course, nothing is so straightforward. And you've seen this slide before, but it's really just to highlight that amyloidosis can present in a million different ways, and most of these symptoms here are equally can be symptoms of other more common diseases. So diabetes is the most common cause of neuropathy in the developed world, and if you have diabetes for a long time, you'll almost certainly have a neuropathy. You'll probably have autonomic symptoms. You may well have carpal tunnel syndrome and renal failure. You'll probably have a bit of heart disease and eye disease. So you'll have almost all of the symptoms, that could also be due to amyloidosis. So it is not always so straightforward to think about it. So, but we have lots of opportunities to diagnose it early. So we've heard about connective tissue. So TTR amyloid loves connective tissue like tendons, ligaments, the flexor retinaculum, which is here on your carpal tunnel. And we know that if we look for amyloid when someone is having a carpal tunnel decompression, we'll find it in at least 20% of people over the age of 50. The problem is that carpal tunnel syndrome is really common. It affects at least 4% of the adult population. And in Ireland, there are about 1,700 carpal tunnel decompressions done every year. And so, if you were to stain all of those, you'd find 340 plus or minus patients probably with amyloid, but it is not routine to stain samples when you do carpal tunnel decompression. So that's the first problem. The other thing is that carpal tunnel syndrome usually is not diagnosed by neurologists. Generally, it's diagnosed by GPs, various medical and surgical specialties, and then the procedure is done by a range of different surgeons, but particularly orthopedics, plastic surgery and general surgery, and I even found a cardiothoracic surgeon online offering carpal tunnel decompression. And in Ireland, there are 360 consultants in those specialties working in public hospitals, and there are many more working in private hospitals. It's a similar picture with spinal stenosis. So we know that about half of the people having spinal stenosis decompression have TTR amyloid on the biopsy, and there are about 1,200 surgeries for lumbar degenerative disease every year in Ireland, and 166 surgeons doing it in public hospitals and more in private. So the issue here is that it is not routine to send specimens for histology when you do a carpal tunnel or a spinal stenosis decompression. That was one of the recommendations of the model of care. The second is that there are hundreds of surgeons doing these procedures. They come from a number of different specialties. As Alistair said, they haven't heard of amyloidosis since they were in medical school, and they think it's a rare disease. So they're not really thinking of amyloid when they're doing these procedures. There is another issue. Some of you will have read about the NTPF in the news in the week. So for a lot of these operations, there are very long waiting lists. And if you're on a long waiting list in Ireland, at some point the NTPF will offer to outsource you to a private hospital. And so when that happens, you generally get operated on by a different consultant. So even if the consultant that you were referred to knows to send your sample off for histology, looking for amyloid, when you get decanted onto a private list by another consultant, they probably don't know that they're supposed to be taking the sample for amyloid. And that's definitely happened in my experience to some of my patients that I've referred. So there's an issue here of trying to raise awareness in this particular group of clinicians, and we're going to have to change standard practices. The next opportunity is that of pre-symptomatic genetic diagnosis. So if you have a known family history and you get genetic counselling and genetic testing and find that you're a carrier, we know that the recommendations are that you should commence screening to try and pick up amyloid as early as possible. Ideally, you should start screening about 10 years before the predicted age of onset. So for the common Irish T60A mutation, age of onset mid-50s, so we should be starting screening in the mid-40s. If you want to do genetic testing on someone that does not yet have disease, you require genetic counselling. At the moment, there are 9 clinical geneticists and 25 genetic counsellors in Ireland, so low numbers, although actually the ratios are similar in the UK, and they are a lot more than they used to be. But no more than in amyloid, we have a lot of other rare genetic diseases which now have treatments coming on board, so there is increasing demand for genetic counselling. And when I checked last week with our friendly local genetic counsellor, the routine waiting list is 11 months, which actually I thought was good compared to most neurology waiting lists. So to touch on the access, because a lot of people ask me this in clinic, how does it work? So in Ireland, these are the reimbursed treatments that are available, stabiliser and 3 different silencers. And to get reimbursed for a silencer, you do require neuropathy. And reimbursement of all of these expensive drugs for rare diseases is usually done by a thing called a managed access protocol, which is run through the Medicines Management Programme in the HSE. And the way it works in practice is, whoops, wrong way. So myself and Emma Joyce work very closely together, even though we're in different hospitals. And we have an MDT, usually on a Wednesday afternoon, and we go on Zoom and chat to each other about our patients. We look at the results. We see, do they have neuropathy or not? And then we decide which drug is most appropriate for that person. And once we've decided, we complete this 6-page form. It's quite detailed. It requires a lot of information which isn't standard practice to capture, like people's PPS numbers and so on. We have to fill out things like, we have to send along with this form all of the blood results, genetic test, DPD report, echo report, biopsies if they've been done, and the nerve conduction reports. If we have all of that information at our fingertips, it doesn't take too long, but often we have to go scratching around, looking in different hospitals for reports, and it can take a while. Anyway, we send this off to the Medicines Management Programme, and they look at what we've sent them, and they decide whether to approve or decline. So it's not us deciding, just because some people think it is. If they decline it, they send it back to us and say no. And if they approve it, they send an email to the Office of the National Director of Access and Integration, because they hold the purse strings. They look at it, and then they send an email back saying, yes, we approve the reimbursement. And then it's up to the hospital, actually, to pay for the drug. And the hospital pay for the drug. TCP get the drug. They're the home care nursing service, and they deliver the drug to the patient at home. And then subsequently, the hospital have to try and get the money reimbursed from the HSE, which, as you can imagine, is not always straightforward. But if you have all of the information at your fingertips, this process can happen within a few weeks. So the next challenge is access to neurology. Ireland has 64 whole-time equivalent consultant neurologists scattered around the country. We have a lot of hospitals in Ireland. There are 27 Model 3 and 4 hospitals. So a Model 3 and 4 hospital has basically an emergency department and 24/7 admissions. There are lots of other Model 1 and 2 hospitals. So the ones outlined in red have a neurologist in-house at least Monday to Friday. And the ones that are in yellow have an outreach service. In most cases, that's one neurologist driving out from wherever their local bigger hospital is and seeing consults and maybe doing a clinic 1 day a week. And in the other 6 hospitals that don't have any colour, there is no neurology service at all. So it depends where you live, how easy you can access a neurologist. This is the league table of neurology per 100,000 population in Europe. And you can see that in Ireland we have the lowest number of neurologists per population. We've 1.3 per 100,000. And this compares to Georgia, you know, which probably isn't everyone's role model, who have 23.6 neurologists per 100,000 population. And the average in Europe is 9. So we are extremely under-resourced in neurology. So as a result, you should not be surprised that we have very long waiting lists. So these are the number of patients who are waiting for a first ever neurology appointment. And in the last number of years, this has been steadily over 20,000 people waiting for a first appointment. And, you know, with that number of patients on a waiting list and 64 neurologists, the waiting lists are several years, maybe 4 years in some places, it depends. Neurological disease is the leading cause of disability worldwide, and Ireland has the 3rd fastest growing population in the EU. We've also seen a quadrupling of neurology referrals since 2019. So over a 5-year period, a quadrupling of referrals. So it is impossible to keep up with that demand. It's a similar but worse situation for neurophysiology. So neurophysiologists, some of you may have met them. They're the people that stick needles in you and interpret these electrical tests. And we have 14.5 neurophysiologists in Ireland who see adult patients, and they are located in Dublin, Cork and Galway. You can access it from other places, but you have to be referred and drive over. So the waiting lists are equally long. So when it comes to amyloid specifically, I see people with amyloid in my neuropathy clinic. And these are the referrals over the last number of years. So 2017 was my first referral of a patient with hereditary TTR amyloidosis. He was diagnosed in the NAC, actually. So he was my first patient. And year on year since then, apart from a blip due to COVID, you can see a dramatic increase in referrals. Most of these people have a diagnosis before I see them. And already this year, we're at 15, so it's going to be up here this year. So increasing referrals every year. And the type of amyloid, obviously, you know, it's biased because I'm a neurologist, but the vast majority of patients have hereditary TTR. Small amount have wild type AL and other things. And I thought I would show some data just from my cohort. So about half are men, average age of 61, on average a 2-year follow-up. And unfortunately, 6 people have died from advanced disease during the time that I've been seeing them. The biggest source of referral is probably EMA-Joyce. So 42% from cardiology, a quarter from haematology, and then in the last few years, increasing numbers from genetics. And you'll see very small numbers referred from other neurologists, only 5%. So probably that's a lot to do with access to neurology. I see a lot of people who come to my clinic who have TTR amyloidosis. They clearly have neuropathic symptoms and have had those symptoms for a long time and have never before been referred to a neurologist. Partly that's because in some cases it hasn't been recognised as neuropathic. It's been considered to be due to spinal stenosis or, you know, whatever. And sometimes maybe it's just because the GPs are aware of long waiting lists and haven't bothered referring, or because they've thought they've got something else. In terms of the genetic variants, so most patients are Irish, 91% Irish, and 90% have the T60A or T80A, whatever you like to call it. But we do see other mutations, but the vast majority have T60A, which is what you'd expect. And more than half of people have a positive family history at diagnosis, but you might be surprised to hear that that does not speed up diagnosis in most cases. So when we break them down into different groups, a small group are asymptomatic carriers, so they're younger people who've had genetic testing, usually because of family history. We have some people who have a mutation, they have carpal tunnel, but they do not have any other evidence of amyloid. There's a small number of people who are carriers and have some symptoms which are, a bit suspicious, maybe a bit of diarrhea or a bit of tingling, but so far have not been able to prove that they have amyloid, so despite DPD scans, skin biopsies and so on. And then the largest group have confirmed amyloid deposition. And everyone who has confirmed amyloid deposition is on treatment of some sort. The biggest group in my clinic is on silencers, followed by stabilizers, and then a small number of people have been in the CRISPR trial. And unfortunately, so far, we have not had success because the Medicines Management Programme consider this a treatment, so have not reimbursed other treatments, even though this is a trial. We are working on that. The other thing that I think is important is that of this group on silencers, so if you remember I said the silencer is only reimbursed if someone has a neuropathy. 12 of this group do not have a large fibre neuropathy, so they don't have numbness or weakness, and their nerve conduction studies are normal. But with the more advanced nerve conduction studies like QST, so they're the things with the little vibration and the temperature that some of you will have had, pseudoscans or autonomic studies, those were abnormal. Even though they had normal large fibre function, we were able to get silencers for them. So it just highlights the importance of the really detailed extra neurophysiological tests, and they are not available, unfortunately, in most places. To look at the delays, so, in about half of patients, carpal tunnel was the first symptom. And of course, most of them were not diagnosed at that point. A quarter cardiac, a quarter neuropathy, and then other bits and pieces. The mean age at symptom onset is 57, and the mean age at diagnosis is almost 63. So the average delay between the first symptom and the diagnosis is over 4 years. And, that's 4 years too many, because we've heard repeatedly how important early diagnosis is to get on treatment, but there is a delay of 4 years. But I would say that Ireland is not unique in that kind of delay is the same in pretty much any health system you look at. People that present with cardiac symptoms do tend to get a slightly quicker diagnosis than the ones that present with neuropathic symptoms, and that's probably down to access. So to finish up, I would say there's definitely increasing awareness of TTR amyloidosis within cardiology for sure, neurology, neurophysiology and genetics. So that's really great. We're seeing people earlier, and we are making pre-symptomatic diagnoses, and we are screening people now prospectively. So people are definitely getting on treatment at an earlier stage. But we lack good epidemiological data because we do not have a patient registry. There are still lengthy delays to diagnosis, even when people have a known family history. And we have challenges in access, particularly around neurology and neurophysiology. We also have this challenge of the wider target audience, the orthopaedic surgeons, rheumatologists, and everyone else, to try and change practice and start the process of routinely sending samples for histology to look for amyloid at the point where they present with carpal tunnel and spinal stenosis. And finally, I would just say, I hope that everyone agrees here that there is a clear need for additional dedicated resources. We have repeatedly looked for this. We've submitted business cases. We have a model of care, and we just need more resources because the demand is too great. And I'll finish by just thanking people I work with.